Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody, and Ramadan Mubarak to all of us. I hope that Allah is going to accept our prayers and dua during this holy month, inshallah. And I would like to congratulate all our colleagues who got accepted in DIE 2 2024. And for those who did not get accepted, my advice, which I always give it to my colleagues, don't get upset and keep trying and keep practicing, inshallah. It's not the time. When Allah subhanahu wa ta'ala, you read, inshallah, you will get it. لم يأذن الله سبحانه وتعالى بعد ولكن يأذن الله وتصير الأمور على خير ما يرام بإذن الله. Can you hear me well, guys?
Yes, doctor, yes.
Okay,
Yes, sir.
that's good. Okay, today, inshallah, we are going to discuss a respiratory case. I have discussed the cardiology case with you before. I have discussed an abdominal case, and we have discussed a neurology case. I have been asked several times by several colleagues to discuss a respiratory case, and now I'm doing this, inshallah. So our guest today is Dr. Hassan. How are you, Dr. Hassan? Dr. Hassan, can you hear me?
Doctor, please, any record for cardiovascular and previous session?
They are all already posted in my YouTube channel. If you don't have any links, just stay with us. At the end of this session, I'm going to leave my WhatsApp number, or this is my WhatsApp number. You can contact me.
Hello?
I will leave my WhatsApp contact number now in the chat box. You can contact me at the end of this session, inshallah. I will provide you with the whole links of our groups, inshallah. Okay? Okay, Dr. Hassan.
Yes, sir.
Let us
I'm
start
ready.
right now, so not to waste time.
Okay.
Right. Bismillah. Okay, this is a station 1. Sorry, it's station 1. Actually, it's not station 4. Okay, station 1, which is composed of respiratory case in addition to communication case in the setting of the exam. However, we are going now to discuss only a respiratory case, which is going to be a 10 minutes case. 6 minutes you are going to spend them with the patient. You are not allowed to take any kind of any history from the patient. You are just examining. You are just giving the patient some instructions, okay, to facilitate your examination, to pick up findings. And then you are going to spend 4 times with examiners, 2 examiners. One of them is going to be the dominant examiner, who is going to rush you with several queries regarding your findings, regarding your differential diagnosis, and regarding your management. And the other examiner is going to be just an observer. Okay, so Dr. Hassan, are you ready?
Yes, I am.
Okay, that's good. So consider this like a mock exam. Okay, Dr. Hassan?
Okay.
Let me just adjust the time for you. So, right. This is the case in front of us. Could you please read it loudly for us?
Mr. James, Adam is 51 years old, gentleman, complaining of shortness of breath. Kindly examine his chest.
Okay. I want you, Dr. Hassan, to consider yourself in the exam since you open the door until you leave the station. Okay. I want you to go inside. I want you to start by washing your hand. I want you just to tell me what you would like to ask for, what you would like to examine, and I will tell you the findings. Okay?
Okay.
Thank you. Now, proceed now. You enter now, and this is Mr. James in front of you.
I'm going inside, go to the wall, read the instruction, then wash my hand and go to the patient. So,
Okay.
Mr. James, I'm Dr. Hassan. one of the medical doctors today in the clinic. Can I examine you?
Yes, sure, Dr. Hassan.
During my examination, if you feel any pain or discomfort, please let me know.
Okay, that's good. Okay.
Okay, so I will start an examination from the end of the bed, looking to the surrounding, seeing the patient have oxygen connected to oxygen.
Yes,
Then
the patient is connected.
Any sputum pot.
No sputum pot.
Then I will ask the patient to remove his shirt and take deep breath in and out for me.
Okay, the patient is taking deep breath in and out. Nothing obvious.
Okay, so I will ask him to cough for me. Give me a strong cough.
Okay.
Dry cough.
Yes, dry.
Okay, then I will come to the patient, start examination from the hand,
Okay.
looking for any clubbing or
This
nail
is the
changes
hand.
in the color. Okay, there is a clubbing on the hand. Okay, then any palmar erythema?
No palmar erythema.
Any nicotine stain?
No.
Then I will ask the patient to elevate his hand to do flap tremor.
Okay, no flapping tremors.
Then I will ask him to check his pulse while I'm calculating the respiratory rate.
Okay, the pulse is around 84 beats per minute, regular, synchronous, good volume.
Then respiratory rate?
Respiratory rate is around 16 breath per minute.
Okay, then I'm going to check proximal myopathy, if any proximal myopathy.
No proximal myopathy.
Then I will examine inspecting the neck for any raised KVP.
No raised KVP.
Then examine his eye for any bullar or jaundice.
Nothing.
Open your mouth for me to see central cyanosis.
No central cyanosis.
Then I will examine his chest, okay, by inspection, any scar or deformity.
No scars, no deformities by inspection.
Okay, then I will do palpation for the apex.
Okay, apex beat is in the left intercostal space, left fifth mid-clavicular line intercostal space.
Then I will do left parasternal heave.
No left parasternal heave.
Okay, then I will do chest expansion.
Okay, chest expansion is
At
slightly reduced at both bases.
At both bases. Okay. Then I will do.
You want to start your
percussion
examination from anterior or posterior, Dr. Hassan?
from anterior.
Okay. Chest examination a little bit reduced on both bases.
Okay. Then I will do percussion in 3 level.
Okay. Percussion, no. There are dullness bilaterally at both bases.
Okay. So then I will do auscultation.
Okay.
Also 3
By
level.
auscultation, you can hear this. Can you hear that?
Fine crockles.
Can you hear this voice?
Yes. Crockles, fine crockles. Okay.
You want to hear again?
Okay. Can you repeat it again?
Okay.
I will ask the patient to cough if any change in the crockles.
Okay. No changes.
Okay. Then I will ask the patient to sit and I will examine the hyperextension of the neck to examine the trachea, any tracheal deviation.
No tracheal deviation.
Then cricosternal notch.
It's normal.
Distance. Okay. Tracheal tug.
No tracheal tag.
Okay, then I will check for lymphadenopathy.
No palpable lymphadenopathy.
Then I will examine from the back, doing also chest expansion.
Okay, chest expansion now is prominently reduced at both bases bilaterally.
Okay, then I will also do percussion.
Percussion node are dull at both bases bilaterally.
Okay, and auscultation also.
Auscultation is the same findings as anterior. You want to hear again?
No, thank you. I will just press on the sacrum to check for edema.
No sacral edema.
Okay, then I will check for lower limb edema.
No lower limb edema.
Okay, so then I'm going just to listen again for this sound.
Okay, this is the sound.
And also ask the patient to give me a cough if any change.
No changes. Okay, examiners, time up. Okay, Dr. Hassan, present your findings in this patient.
Okay, on examination of this patient, he is connected to oxygen cylinder. Okay, with a respiratory rate of 16, respiratory rate of 16 breath per minute. On examination of the chest, chest expansion is reduced at the lower zone bilaterally. He has also dullness on percussion on the both sides of the bases of the lung, and there is fine crackles on the bilaterally at the base side of the lung, not change with coughing. My summary
Okay.
of and also he had clubbing in his hands.
Okay. What kind of crepitations, Dr. Hassan? Are they inspiratory or expiratory crepitations?
Those are inspiratory crackles.
Okay. So
my summary of my finding feature suggesting of bilateral lower zone fibrosis or differential.
okay. What could be the top differential diagnosis in this patient? You said this patient has got fibrosis. Is that right?
Most probably, he have yes.
Okay. What kind of fibrosis could it be?
Most probably, this is idiopathic pulmonary fibrosis based on the clubbing of the hand of the patient.
Okay. And what else?
Also, from the age of the patient, most probably.
Okay. Very good. Very good. So we are considering the age of the patient, the presence of clubbing, and anything else, especially for the crepitations.
Yes, the site of the crepitation is
the side of the
bilateral
crepitation.
basal.
Okay, that's good. Now, give me the differential diagnosis of lung fibrosis, Dr. Hassan.
For lower zone fibrosis,
Okay.
idiopathic pulmonary fibrosis, and drugs such as methotrexate,
Okay.
such as nitrofurantoin.
Okay. What else?
Also, connective tissue disease such as rheumatoid arthritis and systemic sclerosis.
Okay. Did you find anything suggestive of any connective tissue disease in this patient?
Actually, on the hand, I did not find deformity.
Okay.
And also I couldn't get dry skin in the hand of the patient.
Okay. What else in the lower zone fibrosis?
A part of this, it could be silicosis.
Are you sure? Concerning now, we are talking about lower zone fibrosis. You've mentioned medications, you mentioned idiopathic pulmonary fibrosis, and you mentioned connective tissue disorders. What else?
Okay. A part of this,
if I told you that the patient has got a job of, he was working as a ship worker in the past.
yes, most probably this could be, couldn't remember the exact name of it.
Asbestosis.
Asbestosis.
Okay. Now, tell me about some differential diagnoses of upper zone fibrosis.
Upper zone fibrosis, it could be past medical of tuberculosis,
Okay.
sarcoidosis,
Okay.
and also sarcoidosis, perilosis, and
Okay.
silicosis.
Silicosis.
And
Okay. So silicosis usually does cause upper, not lower. Okay.
Yes.
Now, tell me, all of these differential diagnoses you've mentioned, most likely they are causing symmetrical or bilateral fibrosis. Are you aware of any fibrotic disease which are asymmetrical, which can cause unilateral?
Yes,
fibrosis?
tuberculosis.
Okay,
can
very
cause,
good. And what else?
And long-standing bronchiectasis also can cause unilateral.
Okay. What else?
And aspergillosis also, bronchopulmonary aspergillosis.
Is there anything more common than this? If I told you that the patient has got, for example, some sort of lung cancer, and he has got radiotherapy.
Yes, radiation.
Radiation, yes. So on the top, as you have mentioned, is all pulmonary tuberculosis and radiation. Okay, Dr. Hassan, could you please tell me, you have noticed that this patient has got clubbing.
Yes.
Okay, give me some differential diagnosis of respiratory causes of clubbing apart from idiopathic pulmonary fibrosis.
Also, purulative lung disease can cause clubbing, such as bronchiectasis, such as tuberculosis, and pulmonary fibrosis.
What else?
And cancer.
Cancer. What type of cancer in particular?
A small cell lung cancer.
Are you sure? It can cause, but what is the most common cancer that can cause clubbing?
Yes, adenocarcinoma is associated with clubbing.
It can cause, but what is the most common? Usually it's a squamous cell carcinoma. All of them can cause, but however, the squamous cell carcinoma is the most common cause of clubbing among all causes of lung cancer. You are right. Okay. Is there any other causes of clubbing apart from respiratory causes?
Yes. Clubbing can be associated with chronic liver disease.
Okay.
Also, it can be associated with any cancer anywhere in the body.
Okay.
Also, it can be associated with in cardiovascular. It can be associated with infective endocarditis. It can be associated with atrial myxoma.
Atrial myxoma. Okay. Now, let me ask you one important question, Dr. Hassan. How do you differentiate crepitations of fibrosis from crepitations of bronchiectasis?
Crepitation of bronchiectasis usually is coarse crepitation, and the nature of the crepitation change partially with coughing. While crepitation of fibrosis usually is fine crepitation and not change with coughing.
Okay, very good. Okay, now let me take you to another question. How are you going to manage this patient?
Okay, starting investigation of this patient, we're going to do basic investigation in form of CBC, RFT, LFT, and we're going to do respiratory function test, chest X-ray, and HRCT. And we're going also to do arterial blood gases.
Okay.
Then management, non-pharmacological, in form of educate the patient about his illness and stop smoking if he's a smoker, appropriate vaccination,
Okay.
and also respiratory rehabilitation.
Very good.
Pharmacological, we have to give the patient 90 or birfenidone if it is indicated. Also, we're going to provide the patient with long-term oxygen therapy, also if there is indication.
Okay.
And a part of this,
is there any part of a surgical role in fibrosis?
yes, lung transplant.
Lung transplant in case of what? Of fibrosis?
Yes, it is curative.
No, I mean in which stage of fibrosis? For a simple fibrosis, unilateral, or you mean an extensive bilateral fibrosis, for example, or an extensive unilateral fibrosis? In stages of extensive fibrosis, yes, there is a surgical role of lung transplant, as you have mentioned. Thank you very much, Dr. Hassan.
Thank you. Thank you, sir.
I will give you full mark in this station, mashallah.
Thank you. Thank you, sir. Thank you.
Full mark, yes, full mark. You deserve, wallahi, mashallah alayk. Good luck. Good. Well done. Well done. Okay. I'm really proud of you, wallahi, Dr. Hassan. You've done very well. Okay. So, guys, do you have any questions or any comments? The only thing that I would like to add for you, Dr. Hassan, I told you, consider yourself, okay, in examination setting. After you finish your examination, I was expecting from you to thank Mr. James and to cover Mr. James. Don't forget this. Okay, thank the patient and cover the patient, especially that you have asked the patient to take off his shirt. This is patient's welfare. Okay, don't forget this, Dr. Hassan, and for all of you guys as well. Thank the patient and cover the patient. Okay? Yes, this is a case of idiopathic pulmonary fibrosis, as you have seen here. Okay, and actually, they like the fibrosis too much. I don't know what's the reason behind this. Okay, but it's a very simple case. It's a straightforward case. Okay, and usually, the respiratory cases are limited, by the way, not like abdominal cases, not like cardiovascular cases, not like neurology cases. However, it is one of the most difficult cases, not because of the findings, but because of the issue of the need of examination of the anterior and the posterior part. Okay, what I would like to advise you, Dr. Hassan, and I usually advise this for you and for our colleagues as well, always, if you want to save time in the chest station, always start your examination from the back. Okay? Always start your examination from the back. 99.9% you will get the whole findings from the back. And after you finish the whole examination of the back, examine immediately for the tracheal deviation, tracheal tuck, cricostellar distance, and examine immediately for sacral edema and palpable lymph nodes, and act as if you are examining the anterior part. Just a sort of acting. I'm going to discuss this in a while, inshallah. Okay, so I would like to give you the full, and زي ما بنقول احنا في اللغة العربية الإجابة النموذجية. the perfect presentation of this case. So take it as it is. This is a 51-year-old gentleman, Mr. James, who presented with shortness of breath. He is lying in a 45 degrees and connected to a nasal cannula. On examination, you need to start with the general examination. On examination, he has got bilateral clubbing in the fingers, and you need to notice also the toes. If they are there, most likely they are there. So let us assume that it is present in the toes and fingers. So we are going to say that this patient has got bilateral clubbing in the fingers and toes. Apart from that, chest expansion is reduced at both bases. In addition to that, there are dullness at both bases. In addition to that, there are fine end inspiratory crackles at both bases, unaffected by coughing. Unaffected by coughing. And there is another trick also. You can very easily pick up the crackles of the fibrosis. What is it? In addition to unaffection by the cough, usually the crepitations of fibrosis, usually they become absent or they can be softened when the patient is leaning forward. If you ask the patient to sit and to lean forward, and you start picking up or start listening to the crepitations of the fibrosis, usually you will find them soften or they might be absent. So this is another trick. You can add it to the characteristic features of the crepitations secondary to fibrosis. They are unaffected by the cough. I mean, there is no any change in the tone or in the character of the crepitations by the cough. In addition to that, you can ask the patient to lean forward, and then you will hear the tone, okay, of these crepitations will be lower, will be softened, or might be absent as well. Okay, so we are going to present them like this. There are fine inspiratory crackles at both bases, unaffected by coughing, and soften or getting absent when the patient leaning forward. In addition to that, you need to test for vocal resonance. Don't forget this, Dr. Hassan. 99, 99, 99, 99. Okay, and if the patient cannot speak English, in Arabic, you need to say 44, 44, 44. Don't forget this, vocal resonance. There is no need to do tactile vocal fremitus, but vocal resonance by asking the patient to say 99, 99 are important. There should be a decrease in the vocal resonance at both bases. Important negatives, I'm still presenting my findings. Now I have presented the positive findings. You need also to mention the important negatives. What are the important negatives in the respiratory stations? You need to comment about two important issues: evidence of pulmonary hypertension and evidence of heart failure. Okay, evidence of pulmonary hypertension, there is no left parasternal heave, there is no palpable second heart sound, there is no raised JVP. Raised JVP also is a feature of heart failure. There is no sacral edema, there is no lower limb edema. If you could not find any one of these, so you need to mention it like this. Important negatives are no feature suggestive of heart failure and no feature suggestive of pulmonary edema. Up to this point, you need to mention an impressive point before the conclusion or before the differential diagnosis or before the diagnosis. What is this impressive statement? You need to say to the examiners, to complete my examination, I would like to obtain full sets of observations, including pulse oximeter And I would like to do a bedside ABG in addition to bedside spirometer. So, in conclusion, I believe that Mr. Adam has got lung fibrosis. Full stop. This is the perfect presentation of the respiratory case. I will repeat it again. Mr. Adam is a 51-year-old who presented with shortness of breath. He is lying in a 45 degrees and connected to a nasal cannula. On examination, he has got bilateral finger and toes clubbing. In addition to that, chest expansion is reduced at both bases. There are dullness at the same areas. By auscultation, there are fine end inspiratory crackles at both bases, unaffected by coughing and getting soft or absent when the patient is leaning forward. In addition to that, there is decreased vocal resonance in the same areas. Important negatives: there are no signs of pulmonary hypertension and there are no signs of heart failure. To complete my examination, I would like to obtain full sets of observations, including pulse oximeter, and I would like to do a bedside ABG and spirometer. In a conclusion, I believe that Mr. Adam has got lung fibrosis. And if you are 100% sure about your findings, you can add another impressive finding by saying that in view of Mr. Adam's age, which is more than 50 years, and in view of clubbing, and in view of the presence of bilateral crepitations at both bases, I believe that Mr. Adam has got an idiopathic pulmonary fibrosis. Full stop. This is the perfect presentation of the respiratory case. Do you have any other questions, guys, before I proceed?
Sir, what is the reason for lower zone pulmonary fibrosis?
Again, doctor, could you please raise your voice?
What is the cause for lower zone pulmonary fibrosis?
The causes of lower zone pulmonary fibrosis are medications, most of the connective tissue disorders, idiopathic pulmonary fibrosis, and asbestosis. And by the way, I have posted a very nice session. It's around 5 or 6 minutes in my YouTube channel about the causes of pulmonary fibrosis. You can go and revise it. Okay? Now, let me just take you to this slide. As I have told you guys, chest examination station is one of the difficult stations in PACES, an Irish clinical exam. It is difficult because of the limitation of the time and the need of examination of the anterior and posterior aspects. As I have told you, always my advice is start your examination from the back. Okay? And let me tell you that diagnoses in the chest examination are limited and they can easily picked up. For instance, in case that you found clubbing only by general observation, so it's either a fibrosis or a lung cancer or a bronchiectasis. Full stop. In case you found the patient is coughing with a sputum pot and lots of tissues full of sputum, so what could it be?
Bronchiectasis.
Bronchiectasis. These are small hints. Okay, so all what you need is to train yourself to examine both aspects quickly and wisely. And how to examine wisely? By starting your examination from the back. Always start from the back. Wallahi, believe me, guys, start your examination from the back. I did this in my exam. Okay, it's your time. Nobody is going to blame you. Why did you start your examination from the back? It's my time. I can start from the back and I start from the anterior. All what you need from me is to give you the correct findings. But you are not going to force me to start from the anterior aspect. I would like to start from the posterior aspect. So always start from the back. Keep the patient in an upright position and make sure that the patient is not going to lean forward too much, because as I have told you, if the patient is having a fibrosis, the crepitation of fibrosis is going to be absent or soften, okay, when the patient is leaning forward too much. Keep the patient in an upright position. This is number one. And as I have told you, 99.9%, believe me, if you examine the patient from the back, you will get the findings. And then you just need to act quickly as if you are examining the anterior part. And while doing this, you can start preparing your presentation in a professional way, because you are already concentrating on the anterior aspect by just acting as if you are acting to finish it as quickly as possible. You are just acting. Make sure the patient is in a 45 degrees and you are exposing the whole chest. Never ever examine above clothes. You are not allowed. And never ever forget to wash your hand. And never ever, okay, forget to read your scenario carefully. I will send you in the group, inshallah, the steps or a very nice video concerning or demonstrating the steps of the respiratory system. Now, let me just take you to this slide. This slide is summarizing the whole respiratory pathology. As you can see here, there are several lung pathologies in a very concise and easy way. We have the collapse and pneumonectomy in addition to lobectomy. We have the pneumothorax, we have consolidations, we have pleural effusion, we have COPD, we have fibrosis, and we have bronchiectasis as well. You can see here there are different aspects you need to examine and you need to look for. You need to examine and look for tracheal deviation, the expansion, the percussion node, the breath sounds, and any added sounds, and vocal resonance. There is no need to do tactile vocal fremitus. It's a waste of time in the examination. I'm not saying that it is not important, but I'm saying it is a waste of time in the examination. You don't need to do it. Now, let us come for the collapse and pneumonectomy. Okay, you can find in the collapse, the trachea is going to be deviated toward the collapse. The chest expansion is going to be reduced. Percussion is going to be dull. Breath sounds are going to be low, or sometimes if it is a severe collapse, it might be absent, and there will be no added sounds with reduced vocal resonance. On the other side, in case of lobectomy and pneumonectomy, it will be similar. However, be aware in cases of lobectomy, especially if lobectomy is done long time ago, especially for upper lobectomies, you might find only tracheal deviation toward the lesion, and the whole examination is going to be normal. Do you know the reason behind this, guys? For sure, you will find a thoracotomy scar. You will find a thoracotomy scar with a deviation of the trachea toward the lesion. Otherwise, chest expansion is going to be normal. Percussion node is going to be normal. Breath sound are going to be normal. And vocal resonance is going to be normal as well. So what do you think the rationale behind this?
Compensatory hyperinflation or the remaining
hyperinflation, yes, especially if it is done long time ago for an upper lobectomy. There will be a secondary hyperinflation of other lobes, giving you normal findings. Be aware of this, guys. Okay. However, in cases of pneumonectomy, there will be no space for hyperinflation. Now, let us come to the pneumothorax, as you can see here. Okay, there will be no tracheal deviation if it is simple, or it might be away because of the tension, pneumothorax. Chest expansion is going to be either low or normal. For sure, the percussion node is going to be resonant because the pathology here is full of air. Okay, the breath sound is going to be low, and there will be no added sounds with, for sure, decrease in the vocal resonance. Coming the consolidation, for example, in case of pneumonia, okay, there will be no any change in the tracheal deviation. However, usually there is a slight deviation, normal physiological deviation of the trachea to where, the right or the left, guys? I'm asking a question. The trachea is normally deviated to the right or left, physiological deviation?
To the
Right
other
side.
side.
Right.
To the right.
Right side.
Yes, to the right. Now, chest expansion either is going to be normal or low. Percussion node is going to be dull with bronchial breathing. Do you know the difference between the bronchial breathing and vesicular breathing, guys?
Bronchial breathing are harsh.
Okay, that's good. And for sure, there will be some sort of coarse crepitations with increased vocal resonance in case of consolidation. Now let's come to the effusion. It is difficult, by the way, sometimes to differentiate the dullness from stony dullness, by the way, clinically, unless you are a highly expert person. If you find dullness, say it is only dull. Okay, now, if you can see that the effusion, pneumonectomy or lobectomy and collapse, they almost share the similar findings. Now, how to differentiate?
By tracheal position?
Yes. In lobectomy and pneumonectomy, definitely you are going to find a scar. Is that right?
Yes.
But in effusion, you're not going to find a scar unless the patient underwent something else. But if the patient did not undergo any surgical intervention, you're not going to find a scar in pleural effusion. So this is the first differentiating point. The second differentiating point, in cases of collapse or effusion, you can differentiate by the position of the trachea. In case of effusion, the trachea will be pushed away from the effusion, especially with massive effusion. However, in collapse, it's going to be pulled to where the site of the lesion. Okay, now let us come to the COPD. You can see that unlikely the trachea will be deviated. The chest expansion is going to be reduced. Percussion node is going to be hyper-resonant. And the breath sounds are going to be variable. Might be normal, might be reduced. However, there should be an expiratory wheeze because it's some sort of an obstruction with a prolongation in the expiratory phase, and there will be no change in the vocal resonance. In addition to that, especially with advanced COPD, you are going to find features of hyperinflated chest, which are the tracheal tug and reduced or decreased cricosternal distance, in addition to absence of hepatic and cardiac dullness. In addition to that, the vertical dimension of the chest will be more than the horizontal dimension. All of these features are features of hyperinflated chest. And in bronchiectasis, as we have discussed here, the remaining thing is the fibrosis, as we have discussed, and the remaining thing is the bronchiectasis. In bronchiectasis, you can expect anything. Anything can happen in bronchiectasis. For example, chest expansion is going to be variable. could be normal, it could be decreased. Percussion node also is variable. It could be resonant or it could be dull. However, the vocal resonance is usually normal, and the single differentiating finding is the auscultatory finding, which is characterized by coarse, early, or it might be late. However, the characteristic feature of the crepitation is going to be coarse in inspiratory crackles, changing with cough. And sometimes, if there is some sort of obstruction, you can expect some sort of wheezes, expiratory wheezes. Each of these underlying pathologies has got its own features and its own approach in addition to its own specific management. However, the usual approach of dividing the investigations into general and specific investigations and being systematic in your treatment plan is always advisable. Divide your investigations into general and specific investigations. Divide your treatment into pharmacological and non-pharmacological. By this, you are going to give a good impression to your examiners. I'm going to send this, inshallah, in the WhatsApp group. This slide in the WhatsApp group. It's very useful, it's very concise, and it has got an easy way in memorizing the differentiation between among all lung pathologies. Do you have any other questions? In addition to that, I'm going also to send you the video of the respiratory examination sequence. You have any other questions, guys?
Thank you, sir. Thank you for your time.
You're welcome, Dr. Hassan. Okay. Before we leave, I'm going to leave my phone number here. You can contact me to add you to the WhatsApp group to follow the announcement, inshallah. And I would like to advise all of you guys to keep practicing, keep practicing, keep practicing. This exam needs some sort of knowledge in addition to some sort of being oriented. Believe me, examiners they can easily pick up people who practice very well and people who did not practice at all. Okay? Regarding our colleague who asked me to send the link of the YouTube, okay, just send me in the WhatsApp group. I will send you the whole links, inshallah. Okay? So it was very nice to be with you guys. I would like to thank you, Dr. Hassan. You did very well. Okay, and just keep going, inshallah. Do you have any exam nearby soon, Dr. Hassan?
Thank you, sir. Unfortunately, I did not get a seat in this diet.
In this diet? Well, inshallah. Just keep going, inshallah, and be with us, inshallah. Thank you very much, guys. And just follow up and send me all what you need in my contact number. I will add you to the WhatsApp group. Thank you very much. See you, inshallah, on Saturday, inshallah. Bye-bye.
Thank you.
You're welcome.